Hi, my name is Dr. Autumn Brogan, and I'm an emergency physician at Mayo Clinic. It's a privilege to join all of you today at the 18th British-Ukrainian Symposium. Many of us have cared for patients with acute psychosis at moments of extraordinary vulnerability. Our patients are scared, they're disorganized, and often misunderstood, and sometimes physically restrained before any of us have a chance to fully hear them. Acute psychosis doesn't present politely. It presents loudly, urgently, and often dangerously, not only for patients, but for the clinicians tasked with working and caring for them. Today, I'd like to walk through a structured, evidence-based approach to managing acute psychosis in emergent settings, focused on how we can deliver care that is fast and safe, but also humane, care that minimizes harm while preserving dignity. Beyond the chaos that often comes with a patient presenting with psychosis is a human being having a terrifying experience. And what I'd like to focus on today is how we can respond in these moments with care that is decisive but not reflexive, efficient but not dismissive, and care that prioritizes safety while still preserving dignity. I have no financial disclosures and no conflicts of interest related to this talk. Today, we're going to give you 3 points to take away to help you treat psychotic patients. First, I want you to recognize the difference between primary and secondary psychosis, and we'll also talk about PTSD. Then we will identify steps to managing psychosis. And finally, we'll establish safety plans on how to monitor and treat our patients. Acute psychosis is not rare. In fact, we see about 5 to 6% of all of our emergency department visits related to mental health. And of these, about 10% are related to acute psychosis in the United States. We see similar numbers in Australia. They present in the emergency department, intensive care units, procedural areas, and pre-hospital settings as well. And it's important to know that psychiatry alone does not own the specialty. It's up to all of us to help these patients. On our initial assessment, we want to distinguish between primary psychosis and secondary medical causes. And there's a couple of key fundamental facts that can help us as we make this determination. For primary psychosis, we often are seeing auditory hallucinations. They often have prominent thought disorders and complex delusions. They typically have normal vital signs and are fully oriented. For secondary or medical causes of psychosis, we'll often see patients with visual hallucinations, and they'll fluctuate in their cognition. They might be sleeping one moment and awake the other. They also may have altered mental status and abnormal vital signs. Now, this isn't a perfect black and white picture of what primary and secondary psychosis is, but it is a schematic that can help us look for medical causes early. As we look at secondary causes of psychosis, we want to think about our differential diagnosis. One of the most dangerous cognitive errors is assuming that agitation equals psychiatric illness. And there's a long list of diagnoses that can mimic psychosis. In particular, common ones we see in the emergency department are hypoxia, infection, intoxication, or metabolic derangement, and all can look like psychosis. And the cost of missing these diagnoses is high for our patients. So we want to use a systematic approach and rule out these key diagnoses. Fortunately, we have some clearer guidance now on how to work up patients with acute psychosis. The American College of Emergency Physicians no longer recommends a routine workup, but rather recommends targeting our workup toward the clinical presentation and risk factors that the patient presents with. For new psychosis, we're going to consider getting a complete blood count, comprehensive metabolic panels, and thyroid function tests. And you should also consider whether or not to get a urine toxicology screen. We find that neuroimaging has a very low yield for finding any etiology. It only finds 0 to 2.7% of causes in the cases where a patient doesn't have a neurological deficit. But if they do have a deficit, we would definitely recommend getting imaging. Same thing if they're presenting atypically or in the setting of head trauma. And before we start with any medications that we give the patient, we want to try something called verbal de-escalation or non-pharmacological management. These techniques tend to be understudied, but we do believe that they are a foundation of safe care. These include using clear and calm communication and validating your patient's concerns, even if they're delusional. You want to convey respect and empathy for the patient at all times and modulate your own emotional tone. You also want to look at the environment and make it safer, and that can mean removing potential weapons and positioning yourself near an exit. We also want to limit stimulation, such as bright lights or loud noises. And perhaps most importantly, we want you to slow yourself down. You want to present a mirror image of how you want your patient to appear or act. Patients will mirror our physiology naturally. When medications are necessary, evidence now shows some clear first-line choices that we should be turning to. So droperidol is a first-line agent given intramuscularly at 5 to 10 milligrams. You can also turn to olanzapine, especially if droperidol is unavailable, and that would again be 10 milligrams intramuscularly. We know that it's more effective than Haldol or haloperidol, and it's comparable in efficacy to midazolam, but has way fewer side effects. A third option would be to use that haloperidol, but we do recommend giving it together with promethazine intramuscularly. Together, it has fewer side effects. And at 30 minutes, patients who received both haloperidol with the promethazine were more likely to be asleep or calm compared to just giving that Haldol alone. For intramuscular medications, we do have some recommendations. Benzodiazepines are not recommended routinely for acute psychosis, except for in a couple of special exceptions. And those include alcohol withdrawal, sedative hypnotic withdrawal, or if the patient is intoxicated on stimulants. Midazolam works really quickly, but it carries a real respiratory risk. And our 2026 consensus statements really recommend avoiding routine combination therapy of antipsychotics with benzodiazepines. That's due to this increased adverse effects, especially that drop in respiratory status and drop in blood pressure. And we don't see a clear benefit for giving those medicines together. We also really feel that ketamine should be a rescue agent only after the first-line agents fail. Giving those higher doses, such as 5 milligrams per kilogram IM, can cause patients to be at higher risk of airway compromise. We do recommend a lower dose, such as 2 milligrams per kilogram, if you do have to give this medication to a patient. For cooperative or partially cooperative patients, we always like to look at giving oral medications to our patients, and that's because it preserves dignity and autonomy. The first two options that we would suggest are haloperidol with lorazepam, lorazepam alone, olanzapine, risperidone with lorazepam for agitation but cooperative patients. These oral therapies can often prevent escalation entirely. I want to take a second to talk about a really important topic, and that is post-traumatic stress disorder. with psychotic features. This is especially important in times of conflict or war. We see a lot of these patients having had a history of trauma or combat-themed trauma. The way that we can help distinguish psychosis from PTSD with psychotic features is that a lot of times their hallucinations are going to revolve around the original trauma, or have a combat themed in the cases of veterans. They often have guilt-laden content as part of the hallucination or paranoid delusion. And the paranoia is typically non-bizarre. They have preserved insight, and a lot of times it's strongly associated with a history of major depression. These experiences are often intrusive trauma memories that they're suffering and not a primary psychosis. And by mislabeling them as such can deepen the harm to the patient. For these patients with PTSD, our sedation principles remain the same. It's going to be droperidol, olanzapine, or haloperidol plus promethazine. But benzodiazepines are specifically contraindicated as routine PTSD treatment unless you're also treating withdrawal. Long-term care should emphasize in these patients a trauma-focused psychotherapy, prolonged exposure to EMDR, and atypical antipsychotics like risperidone or aripiprazole may be considered, but evidence still remains limited in these areas. Once you sedate a patient, you do have to monitor them. So you want to use continuous pulse ox, regular vital signs, preferably end-tidal CO2 when it's available, and you should use sedation scoring on these patients. You want to be vigilant for extraparietal symptoms, especially with Haldol alone. Note that these medications can cause QT prolongation, and while Torsades is rare, it is serious. Respiratory depression, especially with your benzodiazepines, is a risk. And also you want to watch for neuroleptic malignant syndrome. While rare, it is deadly, and those symptoms, again, that you would be looking for would be rigidity, fever, autonomic instability, and they can often have a CK level of greater than 1,000. If you have a patient that you're suspicious for NMS, you want to immediately stop the offending medication and provide supportive care. Sometimes these patients may need benzodiazepines, and they may need additional medications as well. In these patients, you want to rule out medical causes before attributing their symptoms to primary psychiatric illness. You want to ensure that they have psychiatric consultation before they're discharged. Those patients that are being discharged from the hospital should be referred to specialty care programs with really close follow-up, and ideally that would be within 72 hours. You want to make sure that the medications you're sending them home on are clear to the patient and not causing any side effects that the patient should not be looking for. You want to provide return precautions to the patient, and you really want to engage any sort of family or friend or community support systems for the patient. For trauma or PTS patients, we would recommend referring them to a trauma specialist or veteran service whenever possible. So in summary, we want to start with de-escalation, rule out medical causes, use our clinical judgment to decide on testing, recognize populations like our PTSD survivors who may need trauma-informed care, and use an evidence-based pharmacological approach to these patients. Make sure to monitor them closely and plan for safe disposition. This approach improves safety, not just efficiency. The evidence base for managing these acute psychosis patients has strengthened significantly in recent years, and we now have clear guidance that allows us to reduce harm, improve dignity, and deliver care that is both decisive and humane. Thank you for your time, your attention, and most importantly, for the care you provide every day. I'm happy to take any questions. Thank you.